Those are all patients that cannot be medically managed. We make sure that medication does not work for those patients, and then they become candidates eventually for epilepsy surgery. Even being a minimally invasive approach, there are risks. And the risks, they sound small, 1%, but they can be very, very severe. God forbidding, a bleeding, a large bleed, it can cause weakness or hemiparesis or visual problems or speech problems can happen, even with minimally invasive approaches. So I think we need to be very careful, very criterious in the way we select those patients. The risks for a complication with medication, they do exist. They're much less. So if we can try to control the seizures with medication, as long as this medication is not giving any side effect, they'll be the first treatment line. If they fail, and then surgery may be considered. That's a very, very good question, and I don't have a straight answer for you. For whatever reasons, it's maybe related to pathology, maybe related to the time that patient has seizures during his life. The brain becomes untreatable. The seizures become untreatable. We have patients that, including patients that were in my surgical list, and 2 weeks before surgery, they call me and say, they are not having seizures, and because we start marijuana, and so we said, we prefer to postpone or cancel surgery. All of those patients, they came back. This is not something that is permanent. It seems to me very transitory. However, I don't have very good information to tell you for sure if marijuana works, how efficient is marijuana in treating those patients. We need to face this seriously. I think we need to establish a study, a control case study, where we can really define the utility of marijuana in treating patients with medically intractable epilepsy. We don't have this information at this point. I think the next step is to different ways to modulate seizures. Even with lasers and localization, still we have a group of patients that cannot treat with what we call conventional surgery or with laser, because sometimes the brain is very epileptogenic. The areas in the brain responsible for the generation of seizures are too widespread. So new treatments can include, for example, neurostimulators, that we can localize a small area in the brain that we can modulate, and we can change the way the brain responds to the seizures, or to lower the threshold for seizure activity. Other possibilities are the implantation of catheters with pharmaco that can also modulate the brain with micropumps. So those are the things that will come hopefully in the next 10 years or so.